Hello, good morning. My name is Paul. Today I'm presenting to you on evidence-based practice in occupational therapy. By the end of our section today, we are supposed to understand the concept of evidence-based practice, recognize its significance in occupational therapy, and then learn ways to integrate evidence-based practice into clinical practice. Few thoughts and questions for us to look at before we start the section. Suppose you have a patient with complex condition that doesn't seem to respond to standard treatment. What steps would you take to search for and apply the most relevant evidence to develop a more effective intervention plan? Then the second question, imagine two occupational therapists treating the same condition but using different approaches. How would we know which approach is better? If you are not sure or uncertain about these answers, then I believe this section is for you. What then is evidence-based practice? Say evidence-based practice refers to the consensus, explicit and judicious use of current best evidence in making decisions about the care of an individual client. It is helpful in the development and implementation of disease management program and clinical guidelines. For instance, there's RCOT guidelines, the OATO guidelines, the EULA guidelines for rheumatology, and etc. etc. Hoffman et al. 2023 mentioned that evidence-based practice enables the provision of quality and individualized service in occupational therapy. Importance of evidence-based practice. One, it enhances clinical decision making. Two, it reduces variability in care and increases effectiveness, thereby avoiding the situations of try and error. Three, it enhances professional accountability, helping align practice with ethical and professional standards. Then finally, it supports lifelong learning, where therapists stay updated with emerging research and trends. Evidence-based practice in occupational therapy is a process that integrates these three key constructs, that is research evidence, clinical practice, and patient values. And the diagram above shows the description. So we have the base and best scientific evidence, clinical experience, and then patient value. And then the integration of these three forms what we call the evidence-based practice. And it's important for optimal clinical decision making. One thing I want you to take note of is that evidence-based practice is not just about research. It is the balanced approach that merges scientific evidence with clinical know-how and patient preference. We want to look at how we can develop evidence-based practice. And like we mentioned, the first key construct is selecting the best evidence. Now, how do we select the best evidence? Use the 5A approach. And the first A is to ask. So in asking, it means that you would want to formulate a research question. And in formulating your research question, you use one framework you can use is the PICO framework, where population, P stands for population, and in population we mean the people under study. So it can be obese population, it can be geriatric population, it can be children, it can be stroke patients, it can be whatever population you want to study. Then the I stands for intervention, which refers to the activity or the treatment you are giving to the population. Then the C, which is comparison, refers to when you want to compare two individual intervention to know probably the efficacy of one over the other. And then O is the outcome of the intervention. Now, after formulating your research question, the next thing you need to do is to search for relevant literature based on your research question. And you can search for it using various databases like the CINAHL, the OTCCA, or the PubMed. After searching through and getting some of this evidence, you would want to appraise this evidence to ensure that it is of a high quality. There are various tools that you can use, but then I would want to look at the CAPS tool. So in applying, critiquing this, the quality of the evidence, then now you integrate the findings into clinical practice, and then you assess and evaluate the effectiveness of it. But before we go on into looking at the last 2 points more critically, I would want us to look at the levels of evidence. We spoke about the quality of evidence. So evidence have some level of hierarchy in terms of its quality. And the one on top is is systematic review, and it's of a high quality because is systematic review are synthesis of various literatures and then drawing conclusions. So based on the fact that various literature from different people have written, individualized study, and then in systematic review, the author picks all of this study together and draw conclusions from, makes it the best available evidence that you can find. Notwithstanding, there are other evidence that are equally good. So we have the randomized control trial, the cohort study, and then many of these other evidence. But then these studies are single primary studies. So in single primary studies, you would need to look out for the study design, the randomization, the blinding, the sampling, the population, and then the sample size used, what sort of intervention was given, and then the significance of the study. So in looking at the significance of the study, we want to talk about the statistical significance and then the clinical significance. When we say a statistical significance, meaning that the study was able to prove some level of benefits. But then you would also need to understand that sometimes that benefit would not necessarily translate into clinical, or would not be clinically relevant. For instance, if you want to use a tool to improve strength, probably you might get a statistically significance of probably 0.1. But then this 0.1, um, I mean, significance you've had might not necessarily translate into clinical significance, or might not necessarily translate into function. Okay, so statistically significant, but then the significance is not enough to translate into function, which makes it not clinically relevant. So we want to look at a case scenario in order for us to understand these things more appropriately. So John is a 58-year-old who has experienced stroke. Um, he has challenges with performing his ADLs due to a reduction in fine motor and then strength. He exhibits moderate motor impairment in his right arm. John has mild cognitive challenges post-stroke, and he's motivated and able to participate actively in therapy. Now, looking at John's situation, and searching through available evidence, one of the evidence, um, the best evidence that we had in improving motor responses for post-stroke patients is the mirror therapy and then the constraint-induced movement therapy. So you can see from these two evidence that both are statistically significant. But then, depending on John's circumstances, it's likely that one would not be clinically significant or effective in improving John's health outcome. So then we still go through the phase of the evidence-based practice. The second phase of it, where the clinician expertise is much more is needed to make or to choose the best available evidence to support what challenge John is facing. So you understand that the CIMT, or the constraint induced movement therapy, is for patients who have some level of strength and would want to build on it, as well as building on their precision. And that is the case for John. Whereas in mirror therapy, it is for patients who are completely paralyzed or have a strength of 0. And then you want to use some visual feedback to activate the motor cortex in the brain to elicit some motor response in the affected limb. But in John's situation, you understand that there is some level of strength. So the best approach to use in this circumstance would be the constraint induced therapy. Furthermore, clients' values and needs also forms parts of the evidence-based approach in our selection. That is, one, John is intrinsically motivated, and then also there are no material or resources to use in performing the CIMT. So it's just a restriction of the unaffected, and then asking the person or John to use the affected. And in so doing, he is able to build strength. So if there is no material at all, if there is nobody present, John is still able to perform this activity at home. And the concept of neuroplasticity, the more you do it, the more you gain strength, or the more you benefit from it. So in this phase, you would recognize that evidence based is the best way to get the best, or to make the best clinical decision. Okay, so I would want to conclude by saying that evidence based is key in effective patient centered OT practice. It integrates research, clinical skills, and patient inputs. And then I would also want to call to action that you would explore further learning resources, looking into the library, or go to various online platforms to build your understanding in these things. And then I would want you to apply this to your studies and then practice. I have a case scenario for you where you apply some of these things that has been taught. So this is to enhance sensory and motor responses in a child with sensory processing disorder. Use all of the processes I've taught you to develop an intervention based on your expertise and patient values. Then I want you to reflect on these things and tell me what challenges you faced, and tell me how you think this would influence your clinical decision. Here are my references.